In the last several classes, we have talked about the most common types of lower extremity wounds. We've talked about arterial ulcers caused by lower extremity arterial disease. We've talked about venous ulcers, and we've talked about neuropathic ulcers. But of course, there are other types of pathology that can cause lower extremity wounds. And in this session, we're going to go over the most common types of atypical leg ulcers. So the first type we're going to talk about is vasculitic ulcers. Some of you may have already seen these. Vasculitic ulcers are caused by damage to the blood vessel wall. When you see the term vasculitis, that tells you it's an inflammatory process. While we're not totally clear exactly what happens to cause damage to the vessel wall, one theory is that there's some type of autoimmune response going on in the body that causes formation of antigen-antibody complexes, and that these antigen-antibody complexes attach to the vessel wall and cause a major inflammatory response. The end result is typically either such intense inflammation that you cause obliteration of the vessel lumen, or such intense inflammation that you actually cause a minor perforation, which allows blood to leak out into the tissues. So vasculitis is a general term meaning inflammation of the vessel wall. It's not specific. It can affect any set of vessels, large vessels, mid-sized vessels, small vessels. But most often we're talking about damage to the mid-sized arteries. Now, in terms of specific causative factors, you can see in the handout, both in the hard copy and on Blackboard, that many times we don't even know what triggered the vasculitic process, the inflammatory process. In some patients, it's an acute allergic reaction, for example, a drug reaction. In some patients, probably the largest group, there's some coexisting autoimmune process like scleroderma, or lupus, or rheumatoid arthritis. But as you see, there's a large group where the cause is considered idiopathic, meaning we don't exactly know. Now, how would you know that you were dealing with a vasculitic ulcer as opposed to an ulcer from some other process? Well, first of all, typical presentation, usually they are located on the lower extremities, but they're typically located on the anterior surface of the lower extremity. So you think about neuropathic ulcers. Neuropathic ulcers are located on the foot. So it's pretty easy to distinguish vasculitic from neuropathic. Venous ulcers are usually located between the ankle and the knee, so there's some overlap there. Arterial ulcers are either located distally in the area farthest from the heart, but can also begin with a traumatic lesion that doesn't heal. So there's some potential overlap in terms of location between vasculitic ulcers and both venous ulcers and arterial ulcers. However, there are other clinical indicators that help you to differentiate. For example, there's usually some clear-cut indication that there's something going on with the vessel. Many times you'll have like petechial lesions or purpuric lesions all the way around the ulcers. That's pretty common, or pretty visible, pretty obvious there. Very, very obvious here where you have hemorrhagic bulla. So very commonly you'll see petechial lesions, you'll see purpuric lesions. You might have ecchymotic or purplish bruise-looking areas either around the ulcers or preceding the ulcers. But I think that one of the most important differentiating factors is the fact that with vasculitic ulcers, because there's an inflammatory process going on, and typically it's systemic, they have additional signs and symptoms. So they'll be complaining of low-grade fever, joint pain, muscle aches, just feeling really bad, tired, fatigued. You don't see that with venous ulcers, you don't see it with arterial ulcers, but you almost always see it with vasculitic ulcers. Now back to the presentation of the ulcers themselves. The size is variable, as you see here. You can have very small, almost pinpoint ulcers. You can have fairly extensive ulcers extending into the deeper tissues. Or you may not have open ulcers at all, just hemorrhagic bulla. Once the ulcers open, they typically are full thickness. They usually do extend into the subcutaneous tissue or even deeper. They are almost always extremely painful, and that helps you to differentiate again. These are ulcers that are painful all the time. When we talked about venous ulcers, we said patients with venous ulcers typically complained of pain that was worse toward the end of the day, worse with dependency, worse when the edema is worse, relieved with elevation. When we talked about arterial ulcers, we said that the pain was typically worse with elevation, worse with activity, relieved by rest and dependency. Uropathic pain is typically very different in that it's a pins and needles kind of shooting, sharp, electric-like pain that is frequently relieved by activity, kind of walking it off. The type of pain that patients complain about in relation to vasculitic ulcers is constant. It's not affected by position. They can't identify anything that makes it better. One of the first patients I saw with a vasculitic ulcer, when I came to her room to evaluate her wound, she's like, don't come past this line. I want you to see my wound, but I don't want you to touch it. It hurts way too bad for anyone to touch it. So extreme pain is one of the classic indicators of vasculitic ulcers. Typically, you'll have minimal exudate because of the major damage to the blood vessel. Many times the ulcer bed is kind of pale, or it may be necrotic. Now again, let's look at differential assessment. We'll come back to this in a later class. But differential assessment of a lower extremity wound basically comes back to pain pattern. That's a huge indicator, a hugely important parameter. Location, characteristics of the wound bed, volume of exudate. So if we were trying to differentiate a vasculitic ulcer from a venous ulcer or from an arterial ulcer, venous ulcer is usually located between the ankle and the knee. These wounds may also be located between the ankle and the knee. But that's the only point of similarity. Venous ulcers typically have a very red, wet wound bed. They're very shallow, and we've already discussed the pain pattern. Vasculitic ulcers, in contrast, acutely painful, pain unaffected by dependency, elevation, activity, lack of activity. Vasculitic ulcers are typically full thickness lesions, so they have depth, and they usually have a pale wound bed or a necrotic wound bed. So pretty easy to differentiate vasculitic ulcers from venous ulcers. Now let's talk about arterial ulcers. Arterial ulcers are going to be characterized by location either distally. Those would not be confused with vasculitic ulcers, but arterial ulcers can also occur on the anterior surface of the leg in response to minor trauma, and that wound just never heals. So from a location perspective, there is overlap between arterial ulcers and vasculitic ulcers. Vasculitic ulcers and arterial ulcers, both very painful. However, with arterial ulcers, typically the pain is relieved by rest and dependency. That's not true of vasculitic ulcers. Both arterial ulcers and vasculitic ulcers are commonly deeper wounds with a pale wound bed and not much exudate. However, patients with vasculitic ulcers differ from those with arterial ulcers in that patients with vasculitic ulcers typically have warm feet, good pulses. If you're able to get an ABI, it's going to be normal. You may not be able to get an ABI because it might be too painful for the patient to allow it. But all of your other vascular indices are typically normal. So warm feet, good capillary refill, normal venous filling time, normal appearance to the skin, the hair, the nails. So in other words, multiple indicators that arterial perfusion is normal, and yet you have these full thickness, pale wounds. Remember the other differentiating factor, systemic symptoms, fatigue, malaise, joint pain, that helps to differentiate a vasculitic ulcer from an arterial ulcer. This is just two more slides showing you vasculitic ulcers. Here you have purpuric lesions that may precede the actual ulceration. And here you have very extensive necrosis. When you have a wound that does not match venous, does not match arterial, does not match neuropathic, that's really all you have to know, because what that tells you is you need help in evaluating this patient and determining the etiology of the wounds. Now, in some centers, the physician that's most likely to be able to assist you in assessment, diagnosis, and management of vasculitic ulcers is your vascular surgeon, but in many centers it's the dermatologist, because the dermatology department is faced with all kinds of atypical wounds. And so many times they're the ones most skilled in differential assessment. You need to find out who handles these wounds in your setting so that whenever you find a wound that you're like, I'm not sure, I don't really know what's going on here, I need someone else to look at this with me, you want to know who to call. Now, as you see on your handout, diagnosis is usually made based on several things. First of all, the clinical presentation, the presence of systemic signs as well as the ulcers. When they do labs, they're checking for elevated sedimentation rate, ANA, CRP, other markers for inflammation. Also, many times they will do a biopsy, and the biopsy is typically obtained at the periphery of the wounds. What they really hope to get is a segment of the vessel so that they can determine if there's inflammation involving the vessel wall. In terms of management, it's going to go back to treatment of the underlying pathology, which is an inflammatory process. So many times they end up on steroids or other anti-inflammatory agents. If it's thought to be part of an allergic reaction, obviously they're going to withdraw the offending drug to interrupt that process. In some cases, they'll do plasmapheresis to try to remove the circulating antigen-antibody complexes. From our perspective, as the wound clinician, we're going to follow the basic principles of moist wound healing, handle your exudate, keep the wound surface moist, prevent infection. However, we're going to be very focused on pain management. And one of our goals is to work with other members of the clinical team to assure that that patient's pain is managed effectively. That might mean lidoderm patches. It might mean using a lidocaine-based gel, or we have to pay attention to pain. Okay, the next ones we're going to talk about are caused by pyoderma gangrenosum. Now, for those of you who are doing ostomy care as well as wound care, you're going to hear this again when we start talking about peristomal pathology. Pyoderma gangrenosum frequently occurs on the lower extremities, but can occur anywhere on the body, including the abdomen, including the peristomal area. Pyoderma gangrenosum, if you break those words down, pyo means purulent, as you know, derma means dermis, gangrenosum means necrosis. This is an acute inflammatory process that may produce purulent drainage that extends through the dermis into the subq most of the time, causes full thickness skin loss and necrosis, and as a result causes scarring. What causes it? Again, just like with vasculitic ulcers, many times the cause is unknown. However, it's much more common to see pyoderma gangrenosum lesions in patients who have some other autoimmune process. For example, Crohn's disease, ulcerative colitis, rheumatoid arthritis, or in patients with malignancies. But it can be a standalone diagnosis when there is no other known autoimmune process. Now, how do the lesions present? Well, they can present anywhere along the lower extremities, as you can see, so they can present along the malleoli. They can present along the posterior surface. They can also present along the anterior surface of the leg. They may start out as a crop of purulent lesions, or they may start as a standalone ulcer that turns into a large crater. There may be necrotic tissue on the surface of the ulcer, or there may be a relatively clean wound bed. In many patients, there's kind of a purple halo around the periphery of the wound, but that is not always true. What is always true is that these wounds are acutely painful, much like vasculitic ulcers. So what did we say about vasculitic ulcers? Acutely painful, full thickness skin loss, can occur anywhere on the lower extremity, more common in patients who have some kind of autoimmune condition. That's exactly what we're saying about pyoderma gangrenosum. What's the difference? Well, the difference in terms of pathology is that vasculitic ulcers, the inflammatory process is actually attacking the vessel wall. That is the organ involved in the acute inflammatory process. Whereas with pyoderma gangrenosum, the target organ is actually the skin, specifically the dermis. So there's a lot of overlap between pyoderma gangrenosum and vasculitic ulcers, but the target organs are different. With pyoderma, you do not have acute inflammation of the blood vessels themselves. You will not have hemorrhagic bulla. You will not have the evidence that there is damage to the vessel and blood is leaking out. One thing that's unique about pyoderma gangrenosum is that most of these lesions demonstrate pathergy. Pathergy means that minor trauma causes a major exacerbation. So in dealing with wounds that are thought or known to be pyoderma gangrenosum lesions, we want to be very careful in wound management. We do not want to take a curette and scrape the wound bed. We do not want to do instrumental debridement. We don't want to do negative pressure wound therapy because all of those therapies involve trauma to the wound bed. We want to use dressings that provide atraumatic removal. So we want to be very careful when we move into topical therapy. How do you diagnose pyoderma? We said that you could diagnose vasculitic ulcers frequently by doing lab tests, by doing biopsies that confirmed inflammation of the vessel wall. With pyoderma gangrenosum, there is no definitive diagnostic test. They can do a biopsy. The biopsy will show acute and chronic inflammation, but it will never come back and read pyoderma gangrenosum. So it's primarily a clinical diagnosis verified by biopsy in terms of the presence of acute and chronic inflammation. But to a large extent, it's a rule-out diagnosis, meaning that you've ruled out other causes for the ulcer. Again, who is likely to be of the greatest assistance to you in identifying pyoderma gangrenosum and treating it? Typically, dermatology. They see these wounds. They see them all over the body. They see them on the lower extremities. How do you treat them? You've got to get the inflammatory process under control. So we start out with high-dose anti-inflammatories like high-dose steroids, dapsone, some of your monoclonal antibodies. It has been treated with Remicade. When you go to conferences and they're talking about pyoderma gangrenosum, they typically report a variety of treatments as being successful in different settings and with different patients, but the one thing that is a common thread is anti-inflammatory. So some clinicians will use low-dose tetracycline or doxycycline, primarily because of its anti-inflammatory effect. Some will use steroids. Some will use a combination of systemic steroids and topical steroids. Other topical anti-inflammatory agents have been used. One dressing that has been shown to be effective is hydrophora blue. It's got that combination of antimicrobial agents, so very effective in reducing bacterial counts on the wound surface, but also has a potent anti-inflammatory effect that is reported anecdotally to reduce pain. Silver dressings are also reported to reduce pain, as are your iodine-based dressings, your Medi Honey, and your PHMB. And what do all of those dressings have in common? They're antibacterial and anti-inflammatory. So bottom line, you've got to treat the acute inflammatory process with some type of systemic anti-inflammatory. You probably want to use an anti-inflammatory agent at the surface of the wound. You want to avoid any kind of traumatic local treatment, so you never do instrumental debridement, you never scrape the wound. And looking at this wound, it clearly needs to be debrided. So you would either use enzymatic debridement, you might use Dakin-soaked gauze using a non-woven gauze to avoid any adherence and any trauma with removal. A lot of you have taken care of patients with sickle cell disease, and you might have taken care of patients with sickle cell ulcers. Sickle cell ulcers are one of the most common ulcers caused by some type of blood dyscrasia. Now you know that sickle cell anemia is characterized by abnormally shaped red blood cells. That when the person is well and they are not in crisis, those red blood cells can pass normally through the blood vessels. Tissue oxygenation occurs normally. There's no acute pain and there are no ulcers. But during crisis, when something triggers a crisis, causes a drop in tissue oxygenation, then those red blood cells turn into sickle-shaped cells. They clog the vessels and they cause an acute ischemic process. That in turn can result in an ulcer. Many times these ulcers are very slow to heal because there may be recurrent episodes of ischemia. Over time, there's enough scar tissue that forms in the soft tissues to interfere with venous return so that they can get a combination arterial venous ulcer that's characterized both by tissue ischemia, by edema, and impaired venous return. Now, typically you find these on the lower third of the leg, many times on the medial malleolus, just where you would find a venous ulcer. The difference is that these ulcers are very slow to heal, unlike venous ulcers, which respond promptly to treatment. And of course, the big giveaway is that these ulcers are occurring in patients who have sickle cell disease. When you ask them when the ulcer began, they are going to date the onset of the ulcer to a particular episode of sickle cell crisis. So that's one of the ways you differentiate. The severe pain associated with sickle cell ulcers is another differentiating factor. Now, in terms of management, what you're going to do is you're going to manage any edema with a compression wrap. You're going to try to prevent recurrent crisis by managing pain, by keeping the patient very well hydrated, by promptly treating any evidence of infection. So keep the patient as healthy as possible. You're going to do topical therapy based on your principles of absorb the exudate, keep the surface moist, provide atraumatic removal. If you're not sure as to whether or not this is a sickle cell ulcer, again, you're going to involve either dermatology or vascular. Most commonly is dermatology. You can see malignant ulcers. The two most common malignant ulcers are basal cell carcinomas and squamous cell carcinomas. Basal cell carcinoma, as we mentioned in a previous class, frequently masquerades as hypertrophic granulation tissue, but is quickly recognized because when you treat that hypertrophic granulation tissue, it promptly recurs or never goes away. With standard hypertrophic granulation tissue, if you treat with silver nitrate, it flattens out pretty quickly and is fairly quickly eliminated. The basal cell carcinoma is easily identified through a biopsy. So when you see an ulcer and you're like, well, it looks like hypertrophic granulation tissue, but I've treated it twice and it keeps coming back, I need to rule out basal cell carcinoma. Absolutely. Get a biopsy. And a biopsy will either verify that this is simply hypertrophic granulation tissue that's very difficult to eliminate, or it will diagnose basal cell carcinoma. Once it's diagnosed as basal cell carcinoma, obviously the patient's going to be managed by dermatology and oncology. Squamous cell carcinomas can also occur, and they're particularly common in areas exposed to the sun, so you're most likely to see them on the head and the neck and the extremities. They frequently have rolled edges. This patient had squamous cell carcinoma. Actually, the patient had a recurrent squamous cell carcinoma. He had developed a squamous cell carcinoma, had been treated with radiation, had been then referred to the wound center for failure to heal. Wound center immediately began standard moist wound healing therapy. The wound initially began to respond and to close in, and then plateaued and started to get bigger. The wound center staff wisely repeated a biopsy, recognizing that this patient was high risk for recurrent squamous cell carcinoma, and that's exactly what they were dealing with. So bottom line for us, we need to recognize that skin malignancies can present as ulcerations. We also need to be aware that chronic wounds can deteriorate into malignancies. Anytime we have a wound that is not responding and we don't know why, anytime we have persistent hypertrophic granulation tissue, anytime we have a wound that is suspicious for squamous cell carcinoma, we should get a biopsy. Probably a lot of you have seen patients with calciphylaxis. It is a very serious and potentially fatal complication. It's most commonly seen in patients with end-stage renal disease who are on dialysis. Not always, but the vast majority of your patients will be patients in end-stage renal disease who are on dialysis. It represents an abnormality in the metabolism and elimination of calcium, so that you end up with high levels of calcium that precipitate out into the tissues and that can cause necrosis of blood vessels. So you see on your handout that the other term that is used for calciphylaxis is calcific small vessel ischemic disease. We see these patients because they come in with acutely painful and typically necrotic wounds. Now, these necrotic wounds are preceded by purpuric painful lesions, nodules. So we might see an erythematous or a purplish purpuric nodule that then deteriorates into a necrotic wound. But pain is a major hallmark of lesions caused by calciphylaxis. Now, the areas where you see calciphylaxis lesions are always soft tissue areas, so we see them on the lower extremities. But you will also see them on the abdomen, especially if the patient is obese. So if they have an abdominal pannus, you can see these lesions there. You'll see them on the breast. You'll see them on the buttocks. Those are the common areas for calciphylaxis lesions. When the patient comes in, their greatest concern is pain. Of course, we're always concerned with accurate diagnosis, with appropriate treatment, but we need to hear that the patient came in because the pain is unbearable, and pain should be way up there on our priority list of things to manage. I want you to notice how high the mortality rate is with calciphylaxis, 60 to 80%. Either because of sepsis or because of internal vascular damage affecting vital organs. It's actually lower now than it used to be. But here's the bottom line. If this patient comes in and they have acutely necrotic or acutely painful necrotic lesions, dealing with the wounds is not your immediate priority. Dealing with the pain and doing a workup, those are your initial priorities. So you may very well elect to paint these wounds with betadine and wrap them in dry gauze and focus on pain control for the patient and work with the clinical team to determine, are we dealing with calciphylaxis or is this something else? So how do they diagnose calciphylaxis? Well, these patients, in addition to having these acute lesions on the lower extremity, frequently have lesions elsewhere, as we have discussed, because there are calcium deposits in the soft tissue. When you do the blood work, they will have elevated calcium levels, elevated phosphate levels. So it's going to be, the patient's history is a tip-off most of the time that end-stage renal disease, patient on dialysis. Their lab values, where you find out what their calcium level is, what their phosphorus level is. They will usually also check parathormone levels because many times there's parathyroid overactivity and high levels of parathormone. And they can do either a bone scan or some simple x-rays looking for calcium deposits in the soft tissue. You should not have calcium in the soft tissue, so if you're picking up what looks like bone in the abdomen, bone in the buttocks, bone in the breast, that is totally abnormal and totally consistent with calciphylaxis. So how do you treat them? Well, if they have hyperparathyroidism, they're going to treat that either medically or surgically to reduce the parathormone levels. They're going to initiate medical therapy and nutrition therapy to normalize calcium and phosphate. So they'll be on a low calcium diet. They'll be on sodium thiosulfate infusions typically that reduces calcium and phosphorus deposits in the tissues and can help to mobilize and break up deposits that have already occurred. You'll see on your handout, pain control, pain control, pain control. Very, very, very high priority. Now, if they can get the patient stabilized from a metabolic and medical perspective, then you can move ahead. Typically, these patients need to be taken to the operating room and debrided under anesthesia. It's going to be way too painful to debride them at the bedside. So until they can take them to the operating room, you would either keep the lesions dry or you would use non-instrumental debridement such as enzymatic or olytic or Jenkins. If the patient's stable, you get the wounds debrided. Then many times you can use a combination of negative pressure wound therapy and then flaps and grafts to close the lesions. Go back to the very high mortality rate. You don't want to get caught up in aggressive wound care at the patient's end of life. So you are always monitoring the patient's overall status, what's going on with the workup and with the management of the underlying condition. Wound care is secondary. So your initial goal, pain control, prevent infection. You move into active wound care where you're focusing on debridement, negative pressure wound therapy, flaps and grafts, only after the patient has been stabilized medically and metabolically. And then the last thing I want to go over are lesions commonly known as NLD lesions. And this is why they're called NLD, because it stands for necrobiosis lipoidica diabeticorum. So we're going to call them NLD. Now these lesions occur almost exclusively in diabetic patients, though there have been other reported cases. The pathology is not well understood at all. As you can see, they almost always occur on the lower extremity, many times in areas of previous trauma on the anterior and lateral surface. Many times they have kind of a waxy appearance, kind of a yellow-pink waxy appearance. These plaques are sometimes painful, sometimes not painful, but they're always of concern to the patient because the patient's like, well, what is this and what's causing it? I've had patients who are very concerned just because they looked bad One lady who was a nurse said, I wish they had figured this out because during the summer, I would like to wear short skirts and short pants. But I can't because these are ugly. And so I always have to wear long skirts or long pants. So what are the issues? Well, one of the issues is we don't know what causes them, so we're not very good at treating them. Second issue is sometimes they're painful. And the third issue is that they're almost always ugly. You see that treatment usually involves systemic or intralesional steroids, which suggests some kind of inflammatory process, even if we don't understand it. So is there something you can offer these patients? Yes, and it's primarily referral to dermatology. So that's the last one we're going to look at. That's not, the ones we have gone over are not an exclusive or, let me back up. We have gone over selected causes for atypical lower extremity wounds. There are other things that can cause lower extremity wounds that we have not gone over. But what you should be focused on at this point is a very clear understanding of venous ulcers, arterial ulcers, neuropathic ulcers, and a very good understanding of how to do differential assessment and management of those big three. You should also be very well aware that there are other causes for lower extremity wounds. Inflammatory processes such as vasculitis and pyoderma gangrenosum, malignant processes, blood dyscrasia such as sickle cell anemia, and metabolic conditions such as end-stage renal disease that can produce calciphylaxis. When you're doing differential assessment for a patient with a lower extremity wound, you're always going to start by gathering your data about your vascular status, sensory motor status. You're always going to look at the wound, get the history, and then you're going to determine, is this a good match for a venous ulcer, and can I move ahead and manage this as if it is a venous ulcer because I'm confident? Am I confident that this is an arterial wound and I know just how to move ahead with that? Am I confident this is neuropathic and I know exactly what I should do to manage this wound? Or am I thinking that maybe something else is going on? This is not a good match to venous, arterial, or neuropathic. It's acutely painful and the pain is unrelated to elevation, dependency, activity. That makes me suspect either a vasculitis or a pyoderma. Then I need to get someone else involved in helping me make that diagnosis, someone who can order lab work, who can order and perform a biopsy. If I have a patient who also has a diagnosis of end-stage renal disease and is on dialysis, who presents with acutely painful necrotic wounds or acutely painful indurated nodules, I should suspect calciphylaxis. If I have an atypical appearing wound that looks like persistent hypertrophic granulation tissue or has rolled edges, I should do a biopsy. So we're always focused primarily on our big three, but we also have in the back of our mind, there are other causes for lower extremity wounds. If it's not a good match to the big three, then what I know I need to do is pull someone else in, typically dermatology, to help me do a workup so that I end up with a definitive diagnosis and a pathway for management. Thank you.